Hi everyone, and welcome back to the Dysphagia Matters podcast. I'm Jule.
And I'm Julia.
Tracheostomy care in infants and children brings a whole new level of complexity, needing a totally unique approach to anatomy, development, and therefore also therapy.
Beyond just managing the swallow, we're looking at the reasons why children have these tracheostomies, the therapy needs, and how we can support families through this difficult time. Plus, what it takes when these kids transition into adult services.
To help us unpack all of this, we're super excited to welcome Louise Edwards. She's an expert clinical specialist, PhD researcher, and author of a review on tracheostomy transitions.
Enjoy the episode. Hello and welcome to the Dysphagia Matters podcast, Louise. We are really happy to have you with us today.
Thank you so much for the welcome and for inviting me. Very excited.
Hi, Louise. Great to meet you. Could you start by telling us a little bit about your background and what first drew you to working with infants and children who have tracheostomies?
Yeah, thank you. I think it's a long journey back when I think about how I started in this, and probably like lots of people, got here due to opportunities and seeing and experiencing things that kind of led me down this probably quite random path, and lots of different opportunities along the way. Initially wanting to become a speech therapist actually when I was quite young, having seen one of my friend's sisters have speech therapy for cleft palate, and I'd not really known about the profession then, and then got the privilege, interestingly, sitting with her mum, who is the secretary of a charity then, that's provided advice on feeding for children with cleft palate. So very early, so if I was about 14, I was hearing these conversations and these very challenging conversations around feeding, parents ringing in, asking for support, usually about bottle feeding and breastfeeding and how they could support their child with a cleft lip or palate. So that was really early, and then was fortunate enough to get onto a speech therapy degree, and it was actually my final placement at university where I had the opportunity to go into a pediatric acute setting, which was something I'd not thought of at all. It wasn't in my thinking about sort of professional direction. Certainly was excited about working with children. That was definitely my background, probably a big kid myself, and really enjoyed that fun that you could have. And then ended up, as I say, on this, I actually was on an acute ward. I think it was a neurosciences ward, and was quite excited by the fact that we could work in this field that was quite medically based, but anatomy and physiology. I liked the idea of understanding and working out and trying to troubleshoot. So initially coming out of university, that sort of job wasn't an option, but had worked within community settings with children with a range of needs, including sort of preschool special needs. So actually within that setting had seen a couple of children with tracheostomies, but not actually been involved. And then as my career has gone on, I was very fortunate to have the opportunity to work in a children's hospital very early in my career, and have the opportunity to work with incredible colleagues who are working in this acute setting with children with complex needs, and specifically a big airway centre, so lots of children needing airway support, including invasive ventilation, so tracheostomy, and non-invasive ventilation. My job took me to work into the Pediatric intensive care unit, which again blew my mind at this point in my career. We're talking almost 30 years ago. And so a real steep learning curve, working with colleagues in ENT, craniofacial, and just across that built this experience and found my way with these children and young people. I think and then since then, just lots of different chances to remain curious and try and understand this population and support them along their journey.
That's a great and long journey with many different experiences, I can imagine.
And still going. Like it's that's what's exciting, is we're still finding my way and still making those connections to understand this better, I think. So
yeah, definitely. So for listeners who may not work regularly with this population, what are the most common reasons infants and children require tracheostomy?
It's changed actually across my career, which again, if I have the opportunity to do any education, that's what I've been really interested in, looking at the types of children I perhaps would have been involved with very early on in my career versus now. And I think that's, a real testament to the changes that have occurred in technology. We're advancing technology faster than we've ever seen. We only have to look at our own phones, right? I'm of an era where I didn't have a mobile phone in the first part of my profession. And then we've applied that technology development in the ability to get children out of hospital with portable ventilation, for example, or with technology such as tracheostomy tubes or mask ventilation to support them so they can be managed and sort of live long lives at home. So when we look at these populations, certainly again early in my career, children weren't surviving in infancy if they had an airway obstruction or problems with their upper airway. And so, we weren't seeing those children grow up with tracheostomies. But now what we're seeing is with a, sort of improvement in prematurity, survivability, our mortality rates are reducing, and intervention is earlier, along with pharmacological interventions, team development, skill development across the MDT. So now we're seeing tracheostomies being placed in children at birth, and I think that's a huge difference from the beginning of my career. So as where an infant has been identified in utero with an abnormality that otherwise would restrict their breathing at birth, a tracheostomy can be placed. So it's just mind blowing what we're able to achieve so early on in an infant's journey, and that knowledge to be able to make a difference that early. And then coming forward, what we're seeing is children who are being moved off intubation, so ventilated via mouth, onto tracheostomy so that they can liberate and get them out of hospital, not necessarily free of ventilation, but with ventilation out of hospital. So typically what we see is almost like a 50-50 split. The shift has been to children who require long-term ventilation, so that need to continue supporting their ventilation up to 24 hours a day. But some of those children, it may only be they need it overnight. And the causes of that need can vary. So some of it is about prematurity and lung development. Some of it is about central drive. So some children are born without, when they fall asleep, they stop breathing. So congenital hyperventilation syndrome. So they need a ventilator to support that. And that's typically tracheostomy placed until they're older. And then other children may benefit. So the other kind of side of this would be children who require a tracheostomy to bypass some sort of obstruction in the upper airway. So where the, sort of above where the tracheostomy is placed, so from the voice box or the larynx up, we have some sort of limitation or obstruction. So that might be due to a narrowing, so something called a subglottic stenosis, so a narrowing which is significant enough we can't get airflow, or it might be due to an obstruction due to a tumour or a cyst, something that is, the surgical intervention is not appropriate now because we have a changing and developing system. Or it may be, and less commonly so because it's changed, but, we have jaw placement and tongue placement is further back in the mouth and so obstructing. And then there's a smaller cohort, which is probably looking more towards our older cohort, which are children who require a tracheostomy following a trauma. And that could be a whole range of traumas. So acquired brain injury, spinal cord injury, result of burns or accidental injuries. So there's a big range. And typically what we see is around about 2/3 of tracheostomies are placed in children under 4. So it's that young cohort, and again, that's definitely a shift in my career. And then with the remaining being kind of older children, so more that traumatic caseload. Hopefully that makes sense.
Yeah,
perfect.
It's very impressive. I just thought that what we usually have as SLTs, our distinction of, okay, I work in neurology, I work in ENT, this is everything of that, plus respiratory conditions, everything in one. So you need to know kind of everything for children, right?
Yeah. And I think I think that's the thing I want to celebrate, is in particularly when you look at paediatric acute settings and into community, it's very rare we have the delineation like adults do. So we don't necessarily have roles, and I say this globally as well because I know this is having had conversations with some other countries as well. You kind of become a sort of a specialist of none but master of everything, and so our roles are not, I'm the person that does neuro rehab per se. You have to have an appreciation of the bigger picture. I think that very much speaks to the children with tracheostomy because it is vast ranging. And we have to appreciate some of these children also have other occurring things, so including developmental differences. So I think it is, we do get some specialisation in sort of acute settings and into community. But it's more likely, for my community colleagues, a child with a tracheostomy will be a tiny part of a much bigger caseload.
Yeah, absolutely. And you've already mentioned that those children, of course, grow older and develop. So things are changing. And at one point, if they survive, if everything works out well, they become adults. So maybe looking at those differences between pediatric and adult tracheostomy care, why is it important that clinicians recognize those differences? And we probably shouldn't assume that children are just smaller adults, which we often can read in the literature.
Yeah, it's one of the phrases I'd like to ban. They're not mini adults, and I'm really indebted to my colleagues actually that work in adult tracheostomy, and I've had, the privilege of working in centres where I've had, really close contact with my head and neck colleagues and my adult tracheostomy specialists, the wider MDT. I'm definitely, my knowledge and experience of actually how different they are has come from those experiences and being able to explore both those worlds. And I think, you're absolutely right. I think it's very simple to kind of go, oh yeah, it's just a smaller child with a smaller anatomy with a smaller tube. And I think this then leads itself to make big assumptions then about how dysphagia or eating and drinking and swallowing appears, and also how we may use some of the tools that we use in speech and language therapy to assess swallowing, to assess voice and airway patency. And I think that can be quite damaging. You noted, I think one of the biggest things we need to be mindful of with children is they are developing. And so when you meet a child at the point you meet them, that may not be the same child you meet in the next week, let alone the next year, the next 2 years, the next 10 years. And that applies to all systems. So, we're all subject to the ecosystems around us, whether that's our, anatomy, our physiology, our biology, our social experience, our environmental experience, our cultural context. That all influences how we develop, but that is changeable in childhood. We haven't formed identity. We haven't formed, the neurology to do all the things we need to do. Every single experience we have, positive and negative, impacts the way we're wiring that brain. And so for the child with a tracheostomy, who often has a very unique early experience, and regardless of where we meet them, right? So whether that's the neonate, whether that's the 4-year-old, or whether that's the 8-year-old, they are going through a unique so their first of neurobiology and all those wider social, emotional, psychological experiences. And so we have to take that into context, whereas our adult, sort of counterparts have a plethora of experience behind them that they can then shift and shape and move around. So, we need to remember the context within which children are appearing. Even on a very base level, when we think about the actual airway, we know that airway is really vulnerable to change in pediatrics. So, whereas an adult can tolerate a bit of swelling, so say they've got a tracheostomy and they have an infection, what we know is that they're going to be less compromised than a child that has an infection, where just a millimetre of change in that airway can mean the obstruction of that airway, even with a tube in place. So we need to be really mindful that those differences count. And we can think at lots of different levels. So like the tubes are different. So in certainly, we are seeing in that younger cohort, we're seeing, they have single lumen tubes. So a tube that is just one whole tube. And if that gets blocked, you have to change the whole tube. Whereas in our adults, we typically see double lumen tubes. So where you've got two tubes with an inner tube that if that gets blocked, you remove it, you clean it, you can sort out the airway fairly promptly. I'm being very flippant and not dismissing the work and the competency that's needed, but it can feel very different. And add to that, what we know about children is particularly, when we're thinking about their growth and development, is that they are respiratory vulnerable. So children are more focused on their respiratory health, their lung health, than they are perhaps in our cardiac. So we think of adults, we think cardiac arrest. With children, we think respiratory arrest. So these children are really vulnerable in childhood to that airway that is, sort of out on their neck being compromised. So these things we need to think about, if we're looking at how a patient is appearing, sort of how they're changing, and thinking about what those experiences are, that, the reason for tracheostomy is likely to be very different to an adult. Our adult counterparts, the majority of them will have their tracheostomy within an adult intensive care setting, usually at bedside. They're not going to theatre. Children have to go to theatre to have their tracheostomy because of the anatomy and physiology is less known, and they tend to have their tracheostomy longer. Whereas our adult counterparts, they're having a tracheostomy to wean off ventilation. That's the most typical reason we're seeing tracheostomy in adults. That is not the process for children. If they're having a trachea, they're likely to have it. I think the data is something like at least 2.5 years before they're decannulated, before that tracheostomy is removed. So we're not talking short term. These are long-term placements, which is quite different. And again, thinking about what development is happening in that time.
Yeah, thank you so much for highlighting those differences and why it's so important to actually know about them and recognize them and, not forget about them. From a speech and language therapist perspective, what are the core priorities when working with a child who has a tracheostomy?
I think really honestly, it's remembering there's a child. If I kind of joke to people that I just would love the one thing I leave behind, I'd like to give more than I take, but the one thing I would like to leave behind is that we see the child before the tracheostomy. And it's something I just think we forget. And I understand, I really appreciate, and certainly my research I'm doing at the moment really highlights this, is, this tube in this neck is vulnerable. A parent is managing that tube every single day to save their child's life, to ensure they're still breathing. I am not flippant of the fact of that power of that knowledge. But what I think is important for speech and language therapists to remember why we're in the room. And we're in the room to bring our expertise. We're not the expert in the trachea, never will be, don't need to be. The child has a unique set of circumstances and needs that is really well understood by that family. And we talk a lot, sort of about compassionate care and about the family's the expert, but it seems to be as we step into the room, we remove that expertise from them and we expect to hold everything, and we're expected to know everything about that trachea and everything about the tapes and everything about the suctioning and what they're doing. And parents will look to us to have some knowledge, but you're there as a speech and language therapist to bring that unique set of skills that they don't have access to, that you can empower them with, and you can stand beside them. And the greatest thing you can say to a family is, show me. What does it look like for you? Without going in immediately with, they've got a trachea, so they must look like this. And I think this is particularly important in paediatrics compared to our adult colleagues, where I just think the data and knowledge around adult tracheostomy is far, far superior and far more advanced than paediatrics. And there are reasons for that, which we can touch on. But I think if our biggest job is to stand with the family and see the world from their perspective and how they're managing, because our bits may be significant to me because I'm a speech and language therapist and my job is to support communication and feeding. But actually for them, their job is the fact that they haven't had a carer overnight. They haven't had a carer for the last 3 days. So they've been up for 24 hours solid. They are having to do medical care on a child that they just want to be a mum or a dad or a family member. So I do really speak to this. The word that's used, and I really bow to my esteemed colleague, Professor Sarah Wallace, who talks about humanisation. And I know Todris back in, I think it was mid-2000s, talked about this as a healthcare system. And it is that. We have to be human about this. There's so much going on. And for our families, they've missed out on a lot. You know, they've missed their firsts of a lot. They've missed their first feed. They've missed their first voice. They've missed their first opportunity to play with the other children. And that grief and loss continues. So I'm not saying we need to hold it as speech and language therapists, but we need to be mindful of what we're bringing. We're bringing our skills and knowledge in speech and language therapy. And you know, that's about a developmental context more than anything. Some of these kids spend up to a year in hospital, some cases longer. So it's about ensuring we're supporting their journey. I think that's the priority. I think the skills and knowledge we can build on, but those soft skills, that ability to be with another person in their, I don't want to say trauma, because there's lots of beautiful qualitative stuff that says, you know, some of these families see themselves as resilient, you know, see the power in kind of, you know, surviving and how they've moved forward. But it is standing with them and kind of going, I don't know, but I'm going to find out. It's like I would love to gift that to our profession, that we take the opportunity to go, do you know what? I'm not sure, but I'm willing to go and find out, or I'm willing to find somebody that knows. I used this phrase recently where I think it's Theodore Roosevelt said, people don't care how much we know until they know how much we care. And I think that's really powerful, right? That it's better, you know, I think just give yourself permission to go, I don't know. I think that's more transparent for families, and I think it builds trust. Not always. I definitely have my challenges, but yeah.
Definitely. But it's very important way of looking at it, because we're, on one hand, are not working with one child, but with the entire family, 100%. And with all of their caretakers and siblings and whoever is there around that child. And at the same time, I think it takes off the pressure of us, maybe especially young professionals who are just starting to work in this field. We just talked about all the different conditions and things that lead to tracheostomy. And of course, we cannot know everything, and being open about that and transparent. I think that helps a lot. Thank you for pointing that out. So turning to dysphagia, what are some of the key swallowing and feeding challenges that you often see in the infants and children you work with tracheostomies?
So I think this probably speaks to what I was just saying really about presentation and etiology. You know, we have all cause for children. And I think what the literature tells us is that the tracheostomy, or what is assumed is the tracheostomy, severely disrupts swallowing, or eating, drinking, swallowing in children. And certainly clinically, I've struggled with this because that's not what I've seen. And, you know, short of doing some massive trial that I, you know, wasn't in a position to do, it's been very difficult to translate that. And what we understand is, and certainly the literature now is, like, we've had a real push in the literature to understand this better. But what we do understand is that dysphagia, or you know, swallowing, eating, drinking, swallowing issues occur across the kind of spectrum of needs. So when we think about a tracheostomy, the first place we need to start is that the airflow is bypassing the nose and mouth. So immediately we're missing out on smell and taste. Now, again, if you think about your own experiences of the food that you love, what is it when you smell something cooking, you think, oh yeah, I can't wait for that. Or you smell something cooking and you go, absolutely no way I'm eating that. You know, these children miss out on some of those experiences because we're bypassing the sensory experiences of the nose and mouth, because those responses occur due to airflow over. So clinically, I tend to see taste slightly better than smell, and that's because as a child pulls something into their mouth, you pull some airflow as well. So you get a better taste response than you do smell. But immediately, you know, when we you know, it's more than aspiration, and that's my biggest challenge here, is we need to think about more than aspiration. And I say it cautiously, I said children are respiratory vulnerable. You know, we need to think about lung health across the age range. We know that, you know, prematurity can lead to long-term outcomes for lung condition, you know, long-term issues for lung conditions. But we also need to remember, if you have a premature baby that has a tracheostomy, the prematurity potentially is going to influence what we're seeing from an eating, drinking and swallowing point of view. So those experiences are really important, and it's why we need to think about how they're presenting. Any one of the things I've talked about that might be an indicator for tracheostomy is also an indicator of eating and drinking and swallowing problem, right? So for me, until literally this year, and it's almost like the timing is great, we've not had the data to kind of go, well, which is it? You know, what is the tracheostomy showing us? What is it we're saying about the tracheostomy? And recently there was a paper by a team in Canada, Gupta and colleagues, weeks ago. It's very recent. And it's a paper I'm really excited about because they looked at pre-tracheostomy eating, drinking and swallowing. So they looked at symptomatic or symptom-based dysphagia. And I should be clear about that. So there are some challenges there. Who are we assessing? Because obviously not all children will have symptom-based. There'll be silent aspirators. There'll be the, even the neurologically typical population who have dysphagia. But they highlighted that children who had dysphagia pre also had dysphagia post. So there are population where we then look at going, well, hang on a second. If they've got it pre, then we're dealing with that, and the tracheostomy may not have worsened what's happening. Mm-hmm. And in fact, it may have helped, because now we've got a respiratory system that can collaborate with swallowing, right? Mm-hmm. We're now supporting that system. So they looked specifically, they looked at, and this is where the challenge in pediatrics compared to adults is, we don't have the tools to be able to assess fully a child with feeding and swallowing issues, and particularly if we're looking for neurophysiology and the function, there are limitations on video fluoroscopy and FEES. We do use them and we get great information, but they are a snapshot. And in pediatrics, I think when you've got a developing, changing system, there are limitations. It offers some information, but it doesn't offer all information. And so when we're looking at the different phases of swallowing, we need to think about, what is it we're actually looking at? And is this a consequence of the trachea, or is this a consequence of underlying conditions, or just development and changing? So I think just to point out with that Gupta paper, they do look at, I think something like 25 cases where they had a pre and post video fluoroscopy, and found that, if I remember this correctly, that there wasn't really much difference in penetration aspiration. And in fact, in the penetration aspiration scale, so the Rosenbeck scale, it actually improved, as did the functional oral intake scale improved as well, post-tracheostomy. So I think we do need to be cautious about that because of the measures, and particularly in paediatrics and applying and extrapolating. But I think it's interesting. The other thing they looked at was one-way valve placement, or however you want to call it, one-way speaking valve, one-way valve for me. They looked at those children that were successful at one-way valve placement, pre and post, with and without, and they found that it didn't necessarily improve swallow function. And I think that's a really important, it's really small numbers, but it is backed up by a couple of other people. Streppel in, Marlou Streppel in the Netherlands, she looked at this as well back in 2019. And again, that it's this indication that perhaps a one-way valve in pediatrics doesn't perhaps do the same thing as it does in adults. And there's this challenge of then how do we support this population? And I think just troubleshooting it myself, because I'm desperate to understand it, is we do have different systems. So again, children are respiratory vulnerable, they're respiratory driven. A baby is born unable to sequence suck, swallow, breathe. They've only ever learned how to suck, swallow in utero. We arrive in the world and suddenly we have to breathe. Add into that, we've got a different place to breathe from. So when we add in eating and drinking to the mix, which happens in the upper part of our head and neck, but we're still breathing through our neck, my question is, physiologically, is that really about closing off the lower airway, or is that about organising? Certainly we see thin fluid aspiration is more of a challenge in children with tracheostomy, and the theory, again, that fits with the breathing theory. We're trying to breathe and close in the upper airway, but actually we breathe in the lower airway. And so have we got some timing issues because we're neurologically not timing that right? So lots more questions than answers, really.
Wow. I gotta let this sink in, I think.
It's a lot. I know, it is a lot. And I think
it's really, really interesting and so thought-provoking. And thank you. You've already touched on the speaking valve. So I think looking beyond swallowing and feeding, children with tracheostomies can also face significant challenges with voice and communication, as you've already pointed out. But I think those speaking valves can be, or maybe, be transformative in helping restore airflow through the upper airway and then facilitate voice production and communication. But as you've mentioned, it's not the same as in adults. So how do you approach decisions around speaking valve assessment and use in children?
Yeah, so great. It's one actually, again, really fortunate to kind of have this conversation with colleagues and be curious about it, because I think the data and the literature out there about one-way valve use in pediatrics is great. Like, there's lots. But I always have to emphasize it's highly selected children. And so it is absolutely life-changing to put that valve on and elicit voice. As a clinician, and one of the things I struggle with most is that it's some magic tool. And as I've already referred to, that 50%, up to 50% of this population may have an obstructed upper airway. So putting that valve on is not going to achieve what you want to achieve, and it's contraindicated, right? So we won't get any upper respiratory airflow. So we're not, it's not appropriate to do it. And so we have to be really careful in how we have these conversations, and really well-meaning colleagues will just blurt out, yeah, get a speaking valve on, they'll get talking. And, clinically, we have to be careful with that. Certainly I've been in a very difficult position where we have successfully placed a valve on a child. She screamed the place down. It was amazing. I started crying, because isn't it a privilege that we get to do this? We get to change this airway. We get to impact that voice. And Mum was really angry and sort of spun round on me and she said, this was supposed to be a speaking valve. Where's her speaking? And despite counselling this family a lot, and I'd spent a long journey with them, we'd certainly spent a year together, what the problem, and it's why I rarely use the term speaking valve, is this child actually had significant cognitive and developmental issues. She later went on to have other diagnoses, was primarily vocalising rather than verbal, certainly no language. So whilst I was excited that we had a really positive airflow indication, she indicated emotion, for Mum, it missed the mark. And, it's a real responsibility of voice is our identity. It's the thing when you pick up the phone, you know who that is without looking at the caller ID. It's how we express ourselves. So, people know when you're not having a great day. They can hear it in your voice. They can hear when you're having a great day. And for our families, that pressure to have a talking child is high. Again, looking across the age range, I'm just going to use examples. Trying to elicit voice in a baby that's had a tracheostomy that is snug, so it fits to their trachea as it's supposed to help with positive pressure ventilation, for example. So to get the best out of it, so the ventilator doesn't keep alarming and leaking, means you lose that voice. So how do you support a family, understanding that when their baby cries, you will not hear their cry? And with the best will in the world, clinically, we will tell you this again and again, you can prep that family. I've done pre-tracheostomy counselling. I've supported families' understanding of that. But there is no consolation for meeting your child for the first time and seeing them cry but not hearing them. So we have a responsibility to understand that as we get older, the child who has language, who has speech but has to have a tracheostomy, say, for example, due to a brain injury, spinal cord injury, and they lose that option initially, where's their identity? Their voice will sound different. Even with a one-way valve on, your voice will sound different. It is altered. It is different. It can be amazing and transformative, as we're saying. But for some children, that may not be possible, or it may not feel comfortable, or it doesn't sound like them. That was a young person I worked with years ago, and we happened to cross paths again. She's now a young adult, and she's taught me so much. And one of the things she says is, I hated my voice with the one-way valve on because it wasn't me. So even though we've managed to get to a one-way valve, for her, it wasn't her. And so the responsibility is high in all these, and it's about acknowledging the opportunities. So, if we can get a one-way valve on, let's get a one-way valve on, but we need to ensure we know the airway, We know what's going on. We remind everybody that airway could change. You know, if they get a cough or a cold, that airway can swell and that can prevent an impact on one-way valve. They have a tube change. So if they get a tube that suddenly has a cuff, you know, we need to be mindful that they're high risk if you're using a valve. And we need to understand that for some children, it may be a no, not now, but not a no, not never. And that's something we need to support our wider MDT with as well, because again, well-meaning, you know, you saved a life, you supported a life, right, let's get going, let's put that valve on. And some children, they might have the greatest tube in, so they get lots of airflow around it, and that's amazing, and they might be perfect candidate. You put the valve on and they cannot tolerate it. Physiologically, they just shut, they breath hold, and they just can't cope with it, because it's where they breathe, right? You know, they're breathing in through here and they're expected to suddenly use this upper airway that they may have had little or no experience of. So it's about putting it in the context that it is one of the things we do. We learn communication. We're not born with the skills to communicate. So we need all those beautiful social experiences to be able to develop communication, to change communication, to move through a typical developmental trajectory. So our skills as speech and language therapists begin there, right? You know, we need to bring those skills to the table that, you know, it might be for families and probably the biggest challenge we have to think more broadly. You know, how do we use natural gesture, signing systems or language aided signs, so such as Makaton, sign along, you know, how do we use these, and how do we introduce AAC as a, you know, again, reminding this is not where we're staying. This is about supporting your child share their hopes, wishes, dreams, feelings, emotions, that we need to think broadly about how we support them to have a voice. And that voice may not be what was anticipated, but that they are, you know, for a family, tracheostomies can make a lot of noise, and, you know, saying to a family, can you hear that? Look, you saw when he was getting upset. You're already there. Look at how you're communicating, celebrating what they're already doing. Follow what they're doing, and empower them to access that. I think, I was also just thinking there, I think it's also using what we can. So speech therapists can be good advocates for looking within the MDT to talk about how we manage that airflow. So, you know, for me, whether it's swallowing, whether it's communication, the thing I want is to get some sort of airflow to that larynx. How can we achieve that? And with children, because they're growing and they're changing, the intention usually is to upsize the tube, i.e. give them the next biggest size tube as they're growing. But what that can do is prevent airflow round. And even just passive airflow in children that can't tolerate a one-way valve or have a restricted airflow can offer something of stimulus to that larynx. So not necessarily the same as above cuff vocalization, but that same principle. If we supply airflow, then we get sensory experience, we can stimulate and support. But we have to advocate, is there a possibility to keep that tube smaller? And there are circumstances you wouldn't be able to, where the pressure ventilation needs to be optimized, where they have chronic aspiration. That means, you know, in order to minimize that, it will never stop it, they have to have, say, you know, the biggest option tube or a cuff tube or those needs. So, you know, we know that we can get voice through assistance from the ventilator, for example, so ventilator assisted leak voice. What we don't understand is the impact of voice long term. We don't understand the long-term outcomes for what we're doing to this voice box. So again, I can give you clinically some examples of a young girl that had a one-way valve. She did really well with it, but she didn't have optimal airflow. She did have some obstruction, upper airway obstruction. It was she suffered a valve elsewhere, came to me, and she had an inspiratory S. So, you know, for sock, she would always do a sock inspiratory S, and that's because the airflow was too much. She couldn't get enough airflow up, but that became a pattern. And even as she grew, and she did, you know, she definitely had airflow. She was definitely had vocalizations, but actually it was a pattern that was difficult to change. And the work that hasn't been done is, you know, what's the impact on voice outcomes in these children? And I know there's colleagues that have definitely looked at this. I think a colleague looked at supraglottic voice, and these are just really important things we need to look at in this population, particularly if they are going into adulthood and as their identity forms.
Absolutely, and that only makes clear that you need to know so many things and need to be aware of so many things, even beyond swallowing.
it's a team. And I think, I think that's for me, I really value I've learned so much from my physio colleagues, respiratory physiotherapy colleagues, nursing colleagues, intensivists that have managed to stand me, talk me through a ventilator, which I still bamboozles me, and, nurses and families, I can come with this knowledge, but actually the unique experience of them, and they'll try something and it'll be something that's possibly not on my radar, but it's not appropriate for me to then go, no, this is my agenda. So yeah, it's that collaboration.
Yeah, absolutely. Very impressive. You've already mentioned that now many children with more complex medical needs are surviving also into adulthood. And that, of course, results then in increasing numbers of young people with tracheostomies moving into adult services. You described that also in your review, transitions in tracheostomy care from childhood to adulthood. So from your perspective, what are the most important considerations for SLTs and the wider multidisciplinary team that you've also described when supporting that transition? And how can we ensure that these young people and their families don't feel lost in that process?
Yeah, it's a real challenge, and one that, the review article, is an opinion piece that we were kindly invited to write, which, because we were just curious, my colleague Dr. Jackie McRae and I were just talking about this and going, what happens? Where do they go? And we cited this, and I think this is probably the most important word to come out of it that we made up, for want of a better word. But, we are very aware that children in childhood have more wraparound services and more support. It can definitely not feel like that for families, and I fully appreciate it, but they have a paediatrician, so they have that point, particularly if they've got complex needs, of a paediatrician that is supporting them and supporting their needs, and is at least a central point, to support services and to signpost. When children transition into adulthood, there's no adulttrician. The next person we have that is that wraparound is a geriatrician. So we have this gap where, children are leaving pediatric services and ending up without that kind of central point that is caring for all their needs. And I think the challenge is, particularly when we look at the population that's going over into adulthood, there are two main populations. And again, really nice paper recently. So last year was done by a team in, I think it was Canada again, that looked at transitioning children to adults, and they looked at their cohort of children going across into adulthood, and what they noticed was the children going across were those that had tracheostomy later. So it would be those children that had it perhaps as a result of trauma or something else, and who had severe and complex neurodisability. So they're two quite different cohorts. The severe neurodisability probably had complex needs for a long time and have probably had wraparound services for a long time to a greater or lesser extent. And I should say this is obviously in higher resource settings. I think just to acknowledge, in other settings that may not be the case, and across the age range that might be a challenge. But what we noticed is that if you're a child with a tracheostomy and perhaps no specific diagnosis or diagnosis that gives you an adult equivalent service, where do you go? Because our ENT colleagues aren't necessarily going to keep monitoring them, because, it's not necessarily about the surgery they did. It's about, the needs more wider, sort of more broadly than that. And things like, we need to think about these. Often these families have been trained, they've had a training model and competency around the tubes and the equipment they use, and then they transition into adulthood, and the adulthood expectation is, well, the child is now adult, so they advocate for themselves. And that's a real shift for families going into adult healthcare settings where they may not be allowed to sleep at bedside. They will not be expected to be the carer at bedside. There'll be some different level of expectation for them. The tubes are different. Right? We've gone from a single lumen tube to a double lumen tube. That in itself is a real transition for families. They have been the sole carer of this beautiful airway. They're keeping this patent, and now it shifts and changes. In our adult populations, we know that some of our adults in community settings are doing their own cannula, doing their own changes. And if we can empower young people that are able to do that, fantastic, that's what we'll do. Certainly, I've worked with young people, 12, 13, 14, that have done their own tape changes. So where they have to change their tapes each day, they'll do it themselves. Let's empower them. It's theirs, right? It's in their body. But I think that support for that transition is tricky. I am delighted to hear, though, that, there are now increasing. I know there's a great service in London looking at transition in children to adults. And from what I hear, really great collaborative working across adults and pediatrics, which, just also offers the chance to kind of be curious about that. What does it look like? Because there is little written about that experience. We know any transition is challenging for any of us, whether that is through school or through work or through other experiences. So this one, should be no less challenging and requires as much support. So I think we just need to be aware and, so there's lots of debate, when does transition happen? It shouldn't just be a transfer the day you turn 18. Certainly healthcare in the UK, we talk about it, starting those conversations as early as 12, usually about 14, so that you're getting that awareness and that understanding that this is going to be different, but that doesn't necessarily mean worse. And I think that's the challenge, that's the conversation people get into. And certainly that's not my standpoint. There's services and support even from a rehab point of view. We're so limited on, assessment and rehab in pediatrics. Looking at some of I've had a young person I would have loved to have done pharyngeal manometry on, or pharyngeal stimulation on, electrical stimulation, but we couldn't because he was under 18, yet his diagnosis would have lent itself really well to it. He can transition to adults and receive that support. So, there are real advantages, of those worlds. But yeah, and there is some, there's some great work going on out there, but we just need to understand what that looks like and what support looks like, and how do we communicate that with families that are very used to a paediatric setting, their paediatric team. How do we support that?
Thank you. So now, to put the theory into practice, could you maybe share a memorable child you've worked with who illustrates some of the challenges and perhaps also some of the rewards of pediatric tracheostomy care?
Yeah, I think it goes without saying that every family I come into contact with will offer me an opportunity to learn, to grow, to change, to reflect. But I think it's one young person in particular and family who probably one of the hardest patients I've worked with, and very complex brain tumour, described as, the brain tumour was just scattered around the brain and on cranial nerves, had partial removal, came back from theatre, in intensive care. Again, well-meaning colleagues, family were really anxious about how she presented. I was coming in to start assessment on when we were ready for swallowing and to look at communication. She did have a little bit of voice, but incredibly wet. And one of the nurses leaned in and went, "It's absolutely fine. She'll be eating and drinking in a couple of days' time. It'll be absolutely fine." And as a clinician, my heart sank, because clinically looking at everything, I just wasn't sure we were ever going to get there. Like, for me, just a surface look at, and, a real reminder to remain curious. I just couldn't see it. Understanding what the neurology was, I felt really worried and I felt really upset. I was quite frustrated. Because this nurse, again, well-meaning, I get it. Everyone wants the best. We all want to hope, right? It's really important we don't let that go. But the mum turned to me and said, "See, she is going to eat and drink." And because we'd had some pre-work, she'd already had a tracheostomy before her debulk. And I said, "I'm just not sure. I think we need to look at it." And mum screamed at me, for want of a better. And again, it was so hard. You stand there, and as a clinician, we all talk about zero tolerance, but I could hear the pain. Like, she'd lost something here, and I just needed to hear it. And, totally honest, I had to go away, stand in the sluice, cry. Anybody who's worked in an intensive care unit, that's where you go and cry. Pulled myself together and came back, and I said, "I think we just need to do day by day and work through the journey." Scroll forward, we did plan on things like fees. Video fluoroscopy was not a possibility because the intensive care needs, but we did plan a fees, which I'm so grateful my adult colleagues supported us with. We were doing bits and pieces, but we certainly didn't have a paediatric fee service set up, but we were really clear we needed to understand more. Said that to mum, we do need more information. But what we're seeing at the moment is really tricky. Certainly she had secretions out. But it came to the point where Mum said, I just don't think unless you try something, you're ever going to know. And she's absolutely right. Everything, even with, sort of the greatest anatomy and physiology knowledge and neurology that I had at my fingertips, which was, I had everything from a neurosurgeon. We didn't know unless we gave it a go. Now, I can sit there with my bias of thinking this isn't going to work, but sometimes family just need to give it a go. And so because I was aware of how emotive this was, the young person was now in a high dependency unit. We closed off the unit. We didn't have a nurse in there. Mum was fully trained. It was just me and Mum and the young lady. She chose what she wanted. We went for a chocolate pudding, just a nod to the modified Blue Evans dye test. It's not the thing I would do, just weird blue food, but we do chocolate coloured food to kind of give us that feedback. And we prepped and everything. We were ready for it, and we offered her a spoonful, and she lit up. She was really happy. But it poured out of her tracheostomy. I've never seen anything like it since. I've never experienced it before, but it just all poured out the trachea. Mum looked at me and just froze. And I went, I think we're just going to suction and clean up. And the young girl was like, was it all right? Was it all right? And we said, we're just going to tidy up. I'm just going to go and grab a nurse. Got the nurse in, so could you continue with kind of supporting her, just to let you know she has aspirated significantly. Mum stepped out and burst into tears. And I went with her because I so wanted it to work. Like, I did want it to work. I think that's the thing as clinicians. We do want the best, but it taught me about standing with families and them needing to be on that journey. And, we talk a lot about eating and drinking with acknowledged risk, but it's about, sort of being human again, right? I definitely am the clinician. Back in the day when I first started, our only solution to aspiration was nil by mouth. That's what we did. And we know that swallowing begets swallowing. So why am I going to, for this young lady, actually, if we gave something a go, if we did get that stimulus going, there's a potential she could have improved. Fees, just to clarify, was just, she didn't tolerate it for long. It was just filled with secretions and we couldn't see very much. So it's always been my learning. I will always be grateful to that family for the journey we did together. We worked very hard together. We did make some improvements for her. It's just standing with them. It's their food was everything to them, culturally, personally. It was so important to them. So why would we not, within caution and being really clear about making an informed decision? I mean, that's what we were trying to do. So, yeah, sticks with me. I'll always remember her.
Yeah, thank you so much for sharing the story. It's very impressive and inspiring. If we were having this conversation again in about 5 years' time, what changes would you most hope to see in the care and support provided to children and young people with tracheostomies and, of course, their families?
I think it's a really exciting time. I'm excited about the evidence that's coming through, but we now need to translate it. So some of the papers I've referred to are often retrospective. What can we do prospectively? How can we understand what really happens when we use one-way valves in pediatrics? What is the physiology? What is actually happening with the airflow, the dynamics? I think it's more than a speech therapist role. It's going to take a whole village to understand this. What else is happening? And how can we innovate? For some of our children and young people, having a valve that is a fully closed bias valve is just too much and they need a step up. So, how can we innovate on, open bias valves or variable flow valves to support, that physiology for them? How can we, make it more accessible for them, if that makes sense? So I think for me, it's about innovation. It's about supporting knowledge translation and skill. For me, I'm hoping my research, which is looking at that experience of community therapists, points to a way that we may understand better how we support, the needs that these children have in community settings. This is where they're living. This is where their ecosystems are, right? So we need to support that so they get access to the care they deserve. How do we support families navigate, what can be for some families a long journey? And how do we support transition? What else can we explore about transition? How can we get those pathways better and more accessible? And I think as well, just a nod to the disparities that exist within and beyond countries and borders. Let's let's share more. I've had the privilege of linking in with colleagues in other settings, in other countries, and to really understand that can impact. Our colleagues in low resource countries are so innovative, that we could learn from them. So how do we bring that into the mix so that we really progress our understanding of children and young people with tracheostomies and ultimately see them? So it isn't just about the trachea, that it is the child that we're presented with, and within the family dynamic, within the siblings, within the school, within the life that they had planned. How can we navigate that together?
Amazing. Sounds like a very exciting time, and all the best, of course, to you and your PhD project.
Thank you so much.
We'd like to close with a question from a listener and a guest. She's also been on this podcast, Ulrike Frank. Once you heard that we were going to talk to you, she asked the following question. Is there a network in the Trach community for pediatric tracheostomy care? Is there any way to connect with other clinicians, to exchange knowledge and to learn?
That's a great question. I think... it probably speaks to the 5-year plan, right? That's what we need. We need that community of practice. I'd be so excited about that. I know a colleague in Canada has just done a community of practice for pediatric dysphagia across Canada. That really excites me. There are brilliant organisations like the Global Tracheostomy Collaborative who cover adults and paediatrics and who are looking at those data sets across paediatric and adult hospitals, and there's definitely connections there. We have a Tracheostomy Clinical Excellence Network in the UK, but it's not truly global. And I feel like I've found people just... sort of at events and sort of meeting people. Ulrike's one of them. Colleagues in Australia have just done some lovely work with them. But it's those conversations that I think that would excite me. I feel like now I'm on a mission to get that going. It would be great to have a forum to learn from each other. That's to be curious. And I think there's great power in that. It's great power in kind of navigating borders to understand how we can do better and be better.
Wonderful, beautiful words to end this episode. Thank you so much, Louise, for taking the time and for sharing all your great expertise and your skills and all your experiences with those infants and children and their families. Sharing it with us and our listeners today. Thank you so much.
Thank you for the opportunity.
Thanks so much for listening. If you enjoyed this episode, leave a review wherever you listen to podcasts. You can connect with us on Instagram, LinkedIn and Blue Sky, or visit our website dysphagiamatters.org. We'd love to hear from you. Until next time, take care.